Good evening. I'm really pleased to be here to give this talk to you, and I will say a lot of people title their vagina talks The Secret Garden or The Secret This. I would like the vagina to be a dialogue, because as we're going to talk about, menopausal genitourinary symptoms of menopause are things that are not always talked about. It's not something you sit down with your friends like, oh, my low back, oh, my vagina. But maybe we should. So this is a disclosure. The other disclosure is that some of the things I'm going to talk about are not FDA approved, and I'll try and highlight when that is. So we're going to talk about genitourinary health after menopause, common treatments, some of the newer treatments, and then basic do's and don'ts for your vagina and vulva after menopause. So vaginal health starts with estrogen. And after menopause, estrogen decreases. What does that do to the vagina? It thins the vaginal lining. It decreases blood flow to the vaginal, to the pelvic floor, but also to the vagina. It decreases elasticity and capacity of the vagina. It decreases lubrication, and it changes the bacteria in the vagina. I'll tell you my research focuses on bacteria. I will try not to talk all the time about bacteria, but they are in fact the easiest thing, one of the easiest things of these to measure. And it's very clear when you look at bacteria that estrogen is driving this. So in this study of postmenopausal women, they looked at women who were taking oral hormone replacement, using vaginal hormone replacement, or no therapy. The light gray bars are people who had no lactobacilli. And lactobacilli are the good bacteria in our vagina that make the pH acidic, that help protect against other infections, and we think are anti-inflammatory, which is good for many reasons. The middle bars are people who had moderate lactobacillus, and those large white bars are women who had lots of lactobacillus, which we think is a good, healthy state for the vagina. What you can see is women on systemic hormones or topical hormones had tons of lactobacillus, whereas women not on hormone replacement were much less likely. So again, suggesting estrogen here is driving a lot of the changes in the vagina, which is not a surprise to anyone. But when we talk about therapies, this will be important. So coming to our bacteria, so estrogen is driving this. You get lots of the good bacteria. Is that what determines symptoms? Is it this simple? So this is a study that used a little bit more modern methods of characterizing the bacteria. So it's not culturing them on a dish in the lab, it's sequencing their DNA. It's very CSI. So here each column is a person, each color is a different kind of bacteria, and out of sort of 100% of the bacteria in the vagina, the width of that color is what proportion come from that bacteria. Blue here is the good guys. Light blue is Lactobacillus crispatus. Dark blue is Lactobacillus iners. You don't really have to know who they are, just some people are light blue and some people are dark blue. You can also, these are all postmenopausal women. And a lot of them are blue. And it turns out that the women who on exam with a nurse practitioner had the most dryness on exam were the least likely to be blue, to have the good bacteria. But those women's report of their symptoms did not correlate with the nurse practitioner's exam and did not necessarily correlate with the bacteria found in the vagina. So what are menopausal symptoms? If not the bacteria, if not related to, well, they are related to estrogen, but it's not a simple question, it turns out. And I'm not sure I have the answer for you, but it's certainly one of the things I aim to find out in my research. So we'll come back to the bacteria, but this is just to say that this is, again, kind of a complicated question. So all of us lose estrogen after menopause. Not all of us develop vaginal symptoms. About half of women report vaginal symptoms after menopause. And what are those symptoms? Dryness, dyspareunia, which means pain with sex, irritation or itch, or tenderness or soreness. Dryness is the most common thing that people report, but the thing that brings people to tears in my clinic is the pain with sex, because it ruins people's lives. They feel like they can't do the thing. They're like, finally, the kids are out of the house, for goodness sake, I'm going on vacation, and it's no longer happening for me. So why? I'm not sure we know. In fact, I know we don't know. We're just finishing enrollment in a randomized trial for treatment of genitourinary symptoms in menopause, and 70% or more of the women who enrolled in our trial enrolled because of pain with sex. So hopefully we'll have more of an answer. So it's a big deal. Half of people have symptoms. Did those people talk to their doctor and ask for help with this? Over half of people who reported symptoms in this anonymous online survey, over half of them had never talked to their provider. And the majority of people, it's because I thought I was just normal and I had to live with it. And if I bring anything to you today, it's, dear God, pain in your vagina is not normal. And we should be able to help you. I'm not sure science has gotten us to a place where we can help everyone, but we should be able to try. So other people were embarrassed about it, which I totally understand. Other folks didn't know there were treatments, so we're going to clear that up for everyone here today. There wasn't enough time. The provider wasn't receptive or interested. That is travesty, and that should not happen. Your provider should be interested, and your provider should try and help you. So people may not be talking to their provider, but they're using stuff. So over half of people in this study who had symptoms had used something, and about 60% were using two things that they just bought at the drugstore. So great, self-help, right? This is the 1970s, let's do it ourselves. Well, it turns out the things you buy at the drugstore are not necessarily so good for your vulva. Powder's not so good overall. The topical anesthetics that you can get, anything with benzocaine in it, has been shown in many people to cause this really horrendous contact dermatitis that is worse than the symptoms of menopause. Witch hazel, same thing, really not so good for the vulva. And people have tried all kinds of other things. Yogurt is another common thing people try. It does not work, either orally or applied to the vulva. And the over-the-counter yeast creams, often it's not yeast. It's menopause or it's something else. So while I applaud people trying to take things into their own hands, this is where you really do need to talk to a provider, and we really do need to try and help. So the people who thought I didn't know, A, I didn't know this was a thing, and B, I didn't know there was anything to do about it. Well, it is a thing, and there are things to do about it. So we're going to talk about the standard therapies that have been around for a while, and then some newer and or experimental therapies. And I'll say I think about treating anything in the vagina, but specifically genitourinary symptoms in menopause, as a puzzle. Everyone is an individual. Things that work for one person don't necessarily work for someone else. It may take more than one thing to get people feeling comfortable. And so it is about working together to figure out what's right for you. And that's why there are choices, is because not everything is right for every person. So I'm going to set up these slides. The next couple of slides about treatment are set up with sort of a table that gives you what the thing is, its dosing, what are the established risks, and are there randomized trial data about this. Try and cover cost, and then the three big symptoms of menopause: dryness, pain with sex, and irritation itch. Have people studied whether this treatment helps that, and if so, what does it do? Does it go up or down? So estrogen, obviously, needs to be our first one, because this really does come back to estrogen. I'm not going to talk about oral estrogen, because A, vaginal estrogen for vaginal symptoms is better than oral estrogen, and B, oral estrogen is not recommended as a treatment if all your symptoms have to do with the vagina. So topical estrogen, or estrogen for the vagina, comes as a tablet, as a ring, or as creams. And what I'm talking about here is also low-dose regimens. So estrogen so low as to really not be absorbed much into the systemic circulation, not to require any progesterone to protect the uterus if you still have a uterus, and to really just be providing a local effect, we think. So tablets are dosed 2 times a week. The ring stays in for 3 months at a time. You can have sex with the ring in. For most people, it's relatively comfortable, not everyone. Creams, the dosing is twice a week. And creams are kind of a mixed bag. They can be irritating for some people, and if you're using too much of it, it's easier to give yourself an extra dose of estrogen, because the cream is sort of, you can add a little bit more in the applicator. At higher doses, you could increase your risk of cancer of the uterus, so that risk would still be quite low. There are randomized trials for all of these. They are all effective. in treating genitourinary symptoms of menopause, and they continue to have benefit over, most trials are about 12 weeks, and benefit continues to accrue over the course of the 12 weeks. The downside, Medicare does not cover these, which is, if this was a boy thing, it would be covered. They do decrease all of the symptoms of genitourinary symptoms of menopause, and they're worth it, in my opinion. Although it is, and your provider can often find a cheaper alternative than the $250 if it's not covered. There are compounded options that are much less expensive than that. So one question, many people, estrogen sounds great, right? Like sounds like a fabulous thing, but estrogen we know has a lot of risks. So if I'm putting it in my vagina, are you sure, Dr. Mitchell, that this is going to be okay for me? So in general, there is really very little systemic absorption. In general, may not help it if it's you. So this graph is that dotted line across is 20 picograms per mil, which is about the lower limit of premenopausal estrogen. So above that dotted line is like premenopausal levels of estrogen, although the lower end. Below that line is postmenopausal. There are a bunch of little wavy lines across. The big peak going up is the blood level of estrogen at 8 hours after taking your first dose of Vagifem, which is that tablet, or it's an estradiol vaginal tablet, a low dose. There's a 2-week dose there, there's a 12-week dose there, and you see only one spike. So it seems as though there is only, when your first dose, you get a little bit of a spike that lasts about 8 hours, but the rest of the time your serum estrogen levels are going to be in the postmenopausal range. There may be a little bit of an increase. Our estrogen tests, our blood tests are really not that sensitive, so it's very challenging to say like between 1 and 5. Don't know. Our tests are not that good. So I would like to reassure you that the systemic levels of estrogen are very minimal. This is really a local effect, and it has lots of local benefits. Increases vaginal blood flow, it decreases asymptomatic bacteriuria, or just bacteria in the bladder, and it decreases urge incontinence symptoms, as Dr. von Bargen already mentioned. So this is a good thing. So, is it safe for women who've had breast cancer? And the typical doctor answer is, it depends. It kind of depends on what your oncologists think, because they're really the expert about breast cancer. It depends on if you have a hormone-sensitive tumor. And I think, again, because our blood tests are poor and we can't tell those lower levels of estrogen, I don't think we know. But for most people, probably it is very safe. And so this, if I was going to pick one thing to give to someone with menopause, this would be it, because it works. And it is very low risk, and you do have to keep taking it. It is sort of a long-term project, but twice a week or just one ring every 3 months. For pain-free sex, I think it's a small price to pay. But the $250 is not a small price to pay. So, but say I'm not an estrogen person. I don't want to do estrogen, or my oncologist says I can't do estrogen. What else is out there? So vaginal moisturizers, there are many different kinds. They have all kinds of creative names. I think my favorite is me, again. Dosing is 2 to 3 times a week, or as often as you like. They say on the package insert you can do it as often as you want. Risks are very few. Any kind of product for folks with an irritated vulva can cause more irritation, so it's possible to cause irritation, but overall, most people tolerate these very well. Are there randomized trials? There are some randomized trials. The total number of people in those randomized trials is 122. So I'm not sure that's a huge weight of evidence, and they're not the greatest randomized trials. It's about $30 for a month's worth of therapy. They do decrease all of these symptoms, but most of the benefit occurs in the first 2 weeks of treatment, and after that you don't really get much additional benefit. So you'll know pretty quickly if it works for you or not. So the studies, the randomized trials here have mostly been done in breast cancer survivors, and this is a very good first-line option for folks in that category. So, but really, 2 to 3 times a week, Dr. Mitchell, I don't like it, and it's kind of messy. Okay. So vaginal lubricants are a very event-based treatment. And if you're not having sex very often, if you can plan sex, vaginal lubricants may be all you need. So there are water-based, silicone-based, or oil-based. And oil really could come down to like olive oil or coconut oil from the grocery store, as long as you're not using condoms, because oils will break down condoms. But otherwise, go right ahead. There are not really randomized trials. There's one randomized trial of silicone versus water-based lubricant. People seem to like the silicone-based better, but it's really about 40 people. So we can base our treatment decision on those 40 people or on your personal experience and just try it out. 10 to 20 bucks a bottle, so really pretty cheap. But this has only really been studied for decreasing pain with intercourse. It's not necessarily going to change your dryness symptoms or the itch irritation symptoms. And you really want to check out which lubes. Some people find some lubes very irritating, so you need to look around. These also have really awesome names out there. I'm not going to advocate for any one of those awesome names over another. And so for pain with sex, it may be menopause. But it may be something else. About 20% of women report pain with intercourse lasting for more than 3 months, and that's called vulvodynia, or pain of the vulva. And it's really hard to tell if something is just menopause or if it's also vulvodynia. Both of them lead to, when you have pain with sex, your normal response is to tighten up a little bit, right? Which makes it more painful, which causes more tightness, and it becomes this sort of vicious circle. So whether or not pelvic floor tightness was the cause of the problem, it becomes part of the problem. And so for folks who have long-standing pain, physical therapy to help release and relax those muscles, which really is not going to help your urinary incontinence symptoms that much, but that physical therapy can be a very important part of treating pain with intercourse or pain in general. And lidocaine is just a numbing agent which can help make that kind of physical therapy tolerable and or to help make sex tolerable, especially if sex is very infrequent and if you can plan for it, because you need to put the lidocaine on a little bit ahead of time, which is not feasible for many people. But it can be very helpful. And these, again, it's finding which of these things works for you. For some people, they're like, sweet, this is something I use just when I need it. That's all I want. I don't want to think about this any other time. I'm good. Other people would like a little bit more consistent treatment. So those are the more conventional, more established things we've been using for a long time. Moving on to some of the newer treatments. So ospemifene is a SERM, which is a selective estrogen receptor modulator, which means it's supposed to target just estrogen receptors where you want them, in the vagina. This is FDA approved to treat pain with intercourse after menopause. So it really is for our problem. It's a tablet. You take it daily. It can increase hot flashes. It may have a very slight risk for endometrial precancer. I will say they did a safety study where they did biopsies of the lining of the uterus of people taking this for a year and really saw one person out of somewhere between 50 and 80 women who had a little bit of a change. Everyone else looked postmenopausal, and the person who had a little bit of a change, it was not precancerous. It was just a little bit of a change. So overall, this seems very safe, but that's a small number of people. And we know that as we have more and more people taking medications, very rare problems can be uncovered. So this is still it's relatively new in the past 5 to 10 years. Possibly an increased risk of blood clots, although that, again, is not something that's been borne out in the safety data, but numbers of people are limited. And there are good randomized trials that show that this is effective at decreasing pain with intercourse. I'm going to mention here that, so these are randomized trials where they randomize some people to ospemifene and some people to placebo. 75% of the people in the ospemifene group felt like they had some benefit. 59% felt like they had significant benefit. So they measure the pain score on a scale from 0 to 4. The significant benefit people jumped more than 2 notches on that pain scale. In the placebo group, 30% of people felt like they got better. So when we talk about some of these other therapies that are not as well studied, remember, 30% of people got better from a placebo. And that is not to say their symptoms are not real. That is to say that the mind-body connection is incredibly powerful. And we can do a lot of things with our minds, and so placebos work great because you think they ought to. But when you don't have a placebo control in a trial, it is a problem, and we're going to talk about that later. So an ospemifene treats not just pain with sex, but does seem to have benefit also for dryness and irritation itch. Benefit should be seen by 4 weeks, so you should know pretty quickly, which is good because not a lot of insurance covers this, so you're going to be paying out of pocket in some cases, $200 a month. So similar to estrogen. This is for people who don't really want to take estrogen or don't want a topical, they'd rather take something oral, and whose primary concern is really the pain with intercourse. So you notice my color changed? That's because this is even newer and we have even less data, so it's not like a solid green. It's a light green. It is FDA approved. This is a new medication. So DHEA is dihydroepiandrosterone, which is more of an androgen. So it's avoiding estrogen. It is not an estrogen, although it is a hormone. And the idea is that there is an enzyme inside of cells that converts this into androgens and estrogens. So the benefit here is A, you get the estrogen theoretically just where you need it inside the cells, it's contained. And B, you get a little bit of the androgen, so akin to testosterone, and maybe that's helpful for our vaginal epithelium. I will say there is one study that used a testosterone gel in the vagina, did not really seem to show much benefit from testosterone gel, but DHEA is not testosterone, and so there may be an additional benefit from the androgen in addition to its conversion to estrogen. But probably how it works primarily is its conversion to estrogen inside the body. Most of the studies are done with a suppository, which can cause a little bit of discharge. I think there are tablet forms. The dosing is daily, and it is vaginal. So maybe you have a little bit of discharge from the suppository form. And there are many randomized trials that show benefit in dryness and pain with sex. And I could not for the life of me find out about irritation itch, although they measured it. I just maybe have not looked deep enough into the reports of the trials to see if there's a benefit. What I'll say is here, and also for ospemifene, the treatment group drops their symptom score by about 1.5 points. The placebo group drops their treatment score by 1 point. So it's significant. It's a significant difference. In the ospemifene trials, women used lubricant less often with sex. They attempted sex more often. So there's a real tangible difference in people's lives. I haven't seen that data for progesterone, but similarly, it is a significant difference, although the quantitative number is small. But again, we see about a 20 to 30% placebo response in this kind of trial. We don't know what the cost will be because although it is FDA approved, it is not yet on the market, and my understanding is that the company is sort of negotiating and figuring out what the cost is going to be, and likely to have some sort of payment support program. Benefits should start by 2 weeks and max out by 8 weeks, so it would take 8 weeks to know how much of a benefit you would have from this. So this is on the market, or coming to market, and yet another option in our toolkit. Orange. Caution. So probiotics, all over the shelves at Whole Foods, all over the natural health, they're all over the internet. Bacteria are the answer to everything, right? So lactobacillus is the good vaginal bacteria. There are vaginal lactobacillus suppositories, there are oral things, ultimate vaginal health. Risks are few, GI upset maybe. Randomized trials, no, there are not. One trial of 72 European women using oral probiotics showed a shift in bacterial balance. A different study in different women did not. We don't know if they treat symptoms. In a study that should be coming out in Menopause in the next couple of months, when we asked women about their symptoms, so we didn't do an exam, we didn't sort of check the number of cells, we asked them, how are you feeling? Do you have no symptoms of dryness, mild symptoms of dryness, or moderate to severe symptoms? There was no difference between those three categories in who had lactobacillus and who did not. So I don't think that bacteria are the cause. I think they are a marker in some people, but they are not going to be the cause of symptoms, nor are they going to help us with the treatment. I would love to be proved wrong on that, but I don't think so. Laser. Everyone wants to talk about the laser because it sounds super cool. You could get a vaginal laser 3 times in 6 weeks, and it would take care of your menopausal symptoms for a year. That's what they say. Their studies are, hey, we used this on 80 people and they all got better. There's no placebo control group here. So we don't know. If I told you I was doing a laser, would you feel better? Maybe. So this is not, there are no randomized trials. The data are, I'm skeptically optimistic about this because people do seem to get better. One of the more recent studies I saw said 80% as opposed to 100%. I believe the people who say 80% of people felt better more than the people who say 100% felt better. It is not FDA approved for the vagina. There is no code for us to charge an insurance company, so this is cash only. Biologically, there is a change in the vagina afterwards. So again, skeptically optimistic, but the cash part makes me feel uncomfortable about it. We would like to do the studies the right way, and they should. Some people are doing studies and they should be out, but they're not doing the sham pretend laser study. That would be the right way to do this. So do's and don'ts: do protect your skin. Take care of your skin because it gets more fragile. Do use a lubricant with sex. Do use condoms with new partners, even after menopause. There's still a risk of HIV, especially with fragile vaginal mucosa. So with a new partner, use a condom until everyone gets tested. Consider physical therapy if you're having significant pain with sex for a long duration. And then the don'ts, the big don't is don't assume sex has to be painful because it should not be. So many thanks to all the folks who support my work and to you for listening.